Urticaria and Angioedema, Pathophysiology, Diagnosis, and Management. Urticaria and angioedema are common allergic conditions characterized by transient skin swelling and hives. Understanding their pathophysiology and treatment options is essential for optimal patient management. Understanding urticaria and angioedema, an overview. Urticaria, commonly known as hives, represents one of the most frequently encountered dermatological conditions in clinical practice. Characterized by the development of raised, erythematous wheals on the skin surface, urticaria often presents alongside angioedema, a condition involving deeper layers of tissue swelling. These two conditions frequently coexist but can also occur independently, creating a spectrum of clinical presentations that range from mild and self-limiting to severe and potentially life-threatening. The prevalence of urticaria in the general population underscores its importance as a clinical concern, with studies suggesting that approximately 1/3 of individuals experience at least one episode during their lifetime. Distinguishing urticaria from angioedema. While urticaria and angioedema often occur together, they represent distinct pathophysiological processes affecting different skin layers. Urticaria manifests as superficial, intensely pruritic wheals that appear and resolve relatively rapidly, typically within hours. These lesions involve swelling of the superficial dermis and are often accompanied by a surrounding area of erythema. Angioedema, by contrast, involves deeper layers of skin and mucous membranes, resulting in more substantial and diffuse swelling that can affect facial structures, lips, tongue, and potentially airway tissues. The swelling associated with angioedema typically develops more slowly than urticaria and may persist for longer periods, sometimes spanning 24 to 72 hours. Understanding this distinction is clinically important because angioedema, particularly when involving the airway, requires more urgent intervention and careful monitoring. Pathophysiological mechanisms and triggers. The underlying mechanisms driving urticaria and angioedema involve complex immunological processes centered on mast cell and basophil activation. When triggered, these cells release multiple mediators including histamine, tryptase, leukotrienes, and prostaglandins, which increase vascular permeability and cause local fluid extravasation into surrounding tissues. This cascade results in the characteristic swelling and erythema observed clinically. The triggers initiating this process vary considerably among individuals and include IgE-mediated allergic reactions to foods, medications, insect stings, and environmental allergens, as well as non-allergic mechanisms such as physical stimuli, infections, and systemic conditions. Key points: IgE-mediated reactions, immediate hypersensitivity responses to common allergens such as peanuts, shellfish, tree nuts, and medications like penicillin. Physical triggers: pressure, temperature extremes, vibration, sunlight exposure, and aquagenic stimuli that directly activate mast cells. Infectious agents, bacterial and viral infections that can precipitate urticaria through various immune mechanisms. Systemic conditions, underlying autoimmune diseases, thyroid disorders, and malignancies that may manifest with chronic urticaria. Acute versus chronic presentations. Acute urticaria typically resolves within 6 weeks and usually follows identifiable triggering events or allergen exposures. Most acute cases respond readily to antihistamines and avoidance of causative agents. In contrast, chronic presentations persist beyond the 6-week timeframe and present more challenging diagnostic and therapeutic dilemmas. The most prevalent form of chronic urticaria lacks an identifiable external cause, classified as chronic spontaneous urticaria. This condition is characterized by the recurrent appearance of wheals and angioedema accompanied by significant pruritus, substantially impacting patients' quality of life through sleep disruption, functional limitation, and psychological distress. The distinction between acute and chronic forms guides clinical investigation strategies and treatment escalation. Clinical presentation and symptomatology. Patients with urticaria report intense itching as the predominant symptom, often describing the sensation as burning or stinging. The appearance of individual wheals varies from punctate lesions a few millimeters in diameter to larger confluent areas affecting substantial skin surface areas. Typical wheals display central pallor surrounded by erythematous halos and blanch with direct pressure, distinguishing them from other dermatological conditions. When angioedema accompanies urticaria, patients may report localized swelling of facial features, particularly the lips, eyelids, and tongue, which may feel tight or uncomfortable. In severe cases, involvement of pharyngeal and laryngeal tissues can compromise respiratory function, representing a medical emergency requiring immediate intervention and potential airway management. Diagnostic evaluation and investigation. Diagnosis of urticaria relies primarily on clinical evaluation, as the characteristic appearance of wheals is typically sufficient for identification. However, establishing the underlying cause requires systematic investigation, particularly in chronic presentations. A detailed history exploring temporal relationships between symptom onset and potential triggers provides essential information guiding subsequent investigations. Allergy testing, including skin prick tests and specific IgE measurements, may identify relevant allergens in cases with suspected allergic etiology. For chronic spontaneous urticaria, broader investigation may include laboratory studies to exclude systemic conditions such as thyroid dysfunction, infections, or autoimmune phenomena. Autologous serum skin testing has been employed to evaluate potential autoimmune mechanisms in some chronic cases, though its clinical utility remains debated. Physical examination should assess for dermographism, delayed pressure urticaria, and other physical trigger responses, as identifying specific physical triggers can directly inform management strategies. Treatment approaches and therapeutic options. First-line treatment for both acute and chronic urticaria typically involves second-generation antihistamines, which provide effective symptom control by blocking histamine H1 receptors. Medications such as cetirizine, desloratadine, and fexofenadine offer the advantages of minimal sedation and once-daily dosing compared to earlier antihistamine generations. For patients with inadequate response to standard antihistamine dosing, increasing the dose to 2 to 4 times the recommended amount may provide additional benefit. Systemic corticosteroids play a limited role, reserved primarily for acute presentations with severe symptoms, as prolonged use carries significant adverse effect profiles. Avoiding identified triggers represents a crucial complementary strategy, particularly in acute cases with clearly established causative agents. Advanced therapeutic interventions. Patients with chronic spontaneous urticaria refractory to conventional antihistamine therapy benefit from advanced therapeutic options. Omalizumab, a monoclonal antibody targeting IgE, has demonstrated efficacy in reducing symptom severity and wheals frequency in this population. This biologic therapy represents a paradigm shift in managing chronic urticaria, providing relief for patients who previously endured persistent symptoms despite maximum antihistamine doses. Cyclosporin offers an alternative immunosuppressive approach for highly refractory cases, though its use requires careful monitoring for adverse effects. Emerging therapies targeting additional inflammatory pathways continue to expand treatment possibilities, offering hope for improved outcomes in difficult-to-treat presentations. The selection among these advanced options depends on individual patient factors, disease severity, and response to prior treatments. Managing angioedema, special considerations. Angioedema management requires additional considerations beyond urticaria treatment, particularly when airway compromise becomes a concern. Hereditary angioedema, a distinct condition from allergic angioedema, results from C1 esterase inhibitor deficiency or dysfunction and requires specific therapeutic approaches, including C1 esterase inhibitor replacement or bradykinin receptor antagonists. In acute presentations with potential airway involvement, rapid administration of epinephrine via intramuscular injection represents the definitive emergency treatment, potentially preventing life-threatening airway obstruction. Antihistamines and corticosteroids provide adjunctive benefit but are inadequate as monotherapy in severe cases. Patients with recurrent angioedema episodes, particularly those with family history suggestive of hereditary forms, warrant specific testing to establish the precise etiology and guide long-term prophylactic management strategies. Quality of life impact and patient education. Chronic urticaria and angioedema substantially impact patient functioning and psychological well-being beyond the obvious dermatological manifestations. Sleep disruption from nighttime symptoms, social limitations from visible skin lesions, and anxiety regarding unpredictable flares all contribute to significant quality of life impairment. Comprehensive patient education regarding trigger avoidance, medication administration, and symptom recognition empowers patients to participate actively in disease management. Clear discussion of when to seek emergency care, particularly regarding airway-threatening angioedema, ensures patients understand danger signs requiring immediate intervention. Healthcare providers should recognize the psychological burden these conditions impose and provide supportive counseling or refer to mental health professionals when appropriate. Connecting patients with support resources and educational materials enhances compliance and facilitates better long-term outcomes. Prognosis and long-term outcomes. Most acute urticaria cases resolve spontaneously within weeks to months, particularly when causative triggers are identified and avoided. The prognosis for chronic spontaneous urticaria is more variable, with some patients experiencing gradual improvement over years while others endure persistent symptoms requiring ongoing treatment. However, the expanding array of therapeutic options has substantially improved outcomes for even the most treatment-resistant cases. Regular follow-up assessment allows clinicians to evaluate treatment efficacy, adjust therapy as needed, and monitor for complications or alternative diagnoses. Long-term studies demonstrate that adequate symptom control with appropriate medications significantly improves patient satisfaction and reduces healthcare utilization. Understanding individual disease trajectories and maintaining realistic expectations regarding symptom resolution helps guide therapeutic planning and patient counseling. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.